At 1.5 Tesla, we do not have balloon inflation of the rectum. Therefore, we don't have compression of the peripheral zone of the prostate gland. And now, with a 1 millimeter cut, let's make it even bigger, we can see a round but slightly irregular mass near the midline. Let's scroll it, and it is invading the capsule, isn't it? There's the T2 2D image at 3 millimeters slice thickness. There is the 3D T2 at 1 millimeter slice thickness. And here is the diffusion image demonstrating diffusion restriction of that nodule, which was somewhat hidden by the balloon inflation at 3 Tesla and the associated artifacts from periodic and aperiodic motion. Let's look at this portion of the gland. There is some diffusion restriction present. The left gland is a little more swollen and bigger than the right gland at the mid-level, and there is diffusion restriction, but again, that's a minor criteria in the central region of the prostate, or TZ. Now remember, nodularity is a good thing in the central region. Let's go down to the apex of the gland, down lower. There's some nodularity, but there's also some diffusion restriction. So this one's more well circumscribed. But nodularity is not a good thing in the peripheral zone. So nodularity PZ, danger. Nodularity TZ, not danger. Let's take a look at these areas in the sagittal projection. Let's go to our nodule down low. Here it is. And there it is in the sagittal projection. Better seen without balloon inflation. We don't have all the motion artifacts that we described at 3T. We don't have the susceptibility artifacts that we saw at 3T. Here is the mid and upper portion or base of the gland where there was some mass effect and diffusion restriction. And what about our lesion posteriorly? That one's right there. It's a little harder to see sagittally, but it's clear as day in the axial projection. Let's look at the coronal, just for giggles. The coronal projection, mass effect in the left gland, ill-defined. And the apical nodule area, let's go down there, down to the nodule, down low. Here it is. And pretty hard to see in the coronal, admittedly. Let's look at the ADC map. I think mapping with the axial is probably our easiest bet. Let's go to our lower lesion here. There is diffusion restriction. Not that helpful, but a supplementary finding. Let's go to the larger area of mass effect here. Some diffusion restriction, but ill-defined. And then finally, the key lesion back here, clearly well-defined. So at the very least, we've got a RADS 4 in the PZ, in the middle, PZM, corresponding to a focal nodular area of well-defined diffusion restriction that shows up bright on the diffusion image and dark on the ADC map. These other areas are suspicious. I would personally read them as RADS 3s. One was read as a 3 and one was read as a 4. And at surgery, we have the patient's report. We actually have the biopsy report, but not the surgical report. 7 of 17 cores positive, Gleason 7, 8, and 9, all of them. The left gland was affected in all 3 of those areas. The lower lying nodule near the apex, the more ill-defined mass effect in the middle and base of the gland, and this lesion in the midline entering the capsule was a Gleason 9. So this is an example of 3 Tesla up against 1.5 Tesla. In this example, the 1.5 Tesla wins for the 3 reasons we mentioned. No inflation, very convenient for the patient, don't have to put anything in the rectum. No compression of the prostate gland. Motion artifacts are less. Susceptibility artifacts are less. The case is proven. The patient underwent radical prostatectomy with sparing of the right neurovascular bundle. The left neurovascular bundle was taken down. The patient has scant microscopic midline capsular invasion. The case is proven.